Hello and welcome to this progesterone webinar. It is the 13th of May 2020 and the time is 10:30 p.m. in UAE. I'd like to thank you all for joining us all over the world. My name is Gerard Moore from Focus Gulf Conferences, the webinar support team here. We are the administrators for the webinar. So if you have any technical issues, you can press the admin button on the right hand side of the chat bar to ask us, or you can click reconnect at the top of the screen if you have any audio or visual problems throughout the webinar. The chat bar on the right hand side is for scientific questions that I will be asking to Dr. Matthew at the end of his presentation. This webinar is being recorded and will be live for 3 days after the webinar has finished. Your certificate of attendance will also be sent to you within 3 weeks of the end of the conference. I will now hand over to Mina Ashraf from Lunatis to do the formal introductions and opening of the conference. Mina.
Okay, thank you, Gerard. Ladies and gentlemen, first of all, good evening and Ramadan Kareem to everyone. This evening we are pleased to have a very eminent speaker, Dr. Matthew Pryor, on the occasion of launching Cyclogest in the Middle East markets. My name is Mina Ashraf. I'm the marketing director at Lunatus, and Lunatus is the partner of LD Collins for distributing and promoting Cyclogest in the GCC markets as well as the Levant markets. Today we have Dr. Matt Pryor. Dr. Matt Pryor is a consultant at Newcastle Fertility Center, and he is passionate about working together with patients to provide individualized care. During his training, he was a chair of the Royal College of Obstetricians and Gynecologists Trainees Committee and sat on the prestigious RCOG Council. Dr. Pryor also has been invited all over the world to speak on topics including mitochondrial donation, three-dimensional ultrasound, recurrent pregnancy loss, and reproductive surgery. Dr. Pryor coordinated the Miscarriage Priority Setting Partnership, which for the first time brought women who have experienced miscarriage, others affected by miscarriage, and clinicians together to develop priorities for future research, which is very interesting. And also he was awarded a PhD for research into miscarriage and fertility problems. In Dr. Pryor's role as a Save the Children Health Ambassador, he has visited Liberia and participated in campaigns doing media work and lobbying politicians at Westminster. So we are very pleased to have you with us, Dr. Pryor. It's a pleasure to have you, and the floor is yours. Thank you very much.
Great. Thank you very much, Mina. That was a fantastic introduction. Thank you. I'm really pleased to be here this evening. It's a shame that I'm in my own house up in Newcastle rather than actually with you guys in a real conference, but I guess this is the new world that we live in. So I'm really looking forward to kind of having a discussion about progesterone this evening and its use kind of in the management of miscarriage. I'm going to talk for maybe about sort of half an hour, 40 minutes. Now, in a minute, I'm going to start sharing my slides with you, which means I can no longer see what's going on until we get to a few polls and things. But by all means, ask questions in the chat bar, and Jared and Mina are going to collate those so that at various points and at the end we can have a discussion about what's going on. So I hope you find it useful. I want to say thank you very much to Lunatis and LD Collins for inviting me to speak on this topic this evening, which and I hope you're going to find it useful. So right, let's get into it then. I think I have to share my screen. There we go. So should be able to see the slides now. Can you see them, Mina?
Yes, we can see them, Matt.
Yes,
Thank you.
Fantastic, good. First of all, I was going to tell you who I am. You've probably not heard of me before, but as Mina gave such a comprehensive introduction, essentially, I'm a clinician in the UK, and I've spent the last sort of 10 years really sort of developing my interest in miscarriage. And some of the kind of academic research that I've been involved with when I did my PhD looked at looking at priorities for research in miscarriage, and we'll come out to that shortly. I've also looked at some of the data for the effect of progestogens in pregnancy, and I guess I've kind of gone full circle in that originally I was quite skeptical about the use of progesterone in pregnancy, but as you'll see through this talk today, the evidence has perhaps convinced me otherwise. And most recently, and I guess really what this talk is focused on, is our recent expert opinion paper, which was published in the American Journal with Ari Kumasamy, who I hope most of you have heard of, as he's coordinated both the PROMISE and PRISM trials, which will be key to the talk this evening. And this paper, I'd recommend, it really summarizes kind of what we're going to talk through tonight in a little bit more detail. The slides will be available to you afterwards, and you should be able to click the links to be able to access those papers. So what are we going to talk through this evening? First of all, we're going to have a little bit of a think about miscarriage and kind of what does miscarriage mean. Then we'll look at whether progesterone could be a decent treatment for miscarriage, to prevent miscarriage. We'll then go through the two trials, which are really important and I think have really changed the landscape of the evidence for miscarriage research in the last few years. And then we'll go through the implications of practice. So first of all, let's have a think about kind of miscarriage. And sometimes, I guess, as doctors and clinicians, we think, oh, it's another miscarriage. It's the most common complication of pregnancy. It's something that's minor and not necessarily too important to us as clinicians. But the actual impact of miscarriage, I think, can't really be underestimated. Not only are there the physical kind of awful symptoms of miscarriage with bleeding, pain, and also the complications that can arise, whether people don't have access to healthcare, or even requiring surgical treatment, blood transfusion. It can be a really horrible kind of physical condition for people to have to go through. But beyond that, there's really the kind of the hidden effects of miscarriage and the psychological and emotional impact of miscarriage, which can include anxiety, depression, even post-traumatic stress disorder. And so miscarriage can really have a big impact. Now, that's just me kind of summarizing what kind of we all know about miscarriage, but I think it's most important to kind of think about what patients think about it. And really, I think this sums it up, really. The grief of miscarriage really can last forever. So miscarriage can really have a massive impact on women and those affected by miscarriage's lives. This is a quote from Julia Bueno. She is a counsellor and psychotherapist in the UK, but she went into that after being a patient and suffering several pregnancy losses. And she's the author of a book called The Brink of Being, talking about miscarriage. And I'd really recommend that book for anybody that's interested. So first of all, let's consider it from a patient's perspective. We've got a case study here. A 30-year-old woman. This is someone actually who I saw last week. In fact, I didn't see her. She phoned me up because we're doing reduced face-to-face contact in the UK due to COVID. But she's 30 years old. She's had 7 miscarriages before. In the last 4 pregnancies, the miscarriage was sent for genetic analysis, which showed all the chromosomes were normal, apart from the last one, where the miscarriage showed it was due to trisomy 12. All the other investigations, which include antiphospholipid screen, thyroid antibodies, thyroid function, and 3D ultrasound scan, were completely normal. She's now 6 weeks pregnant, and she woke up last week in the morning with some spotting. said to me, "Doctor, please help me." So I want you to kind of put yourself in my shoes, and we've got 4 options for you. So what I'm going to try now is a poll. Let me get into this. So a poll should appear on your screen, and you've got 4 options. So what can we offer? We can offer support and reassurance scans, progesterone.
Matt, you need to stop screen sharing.
Oh, right, okay, because
Yeah,
I'm just kind of like multiplying myself lots of times, aren't I?
Yes, now start the poll. Now go into poll.
Oh, I'm in the poll, it's going and people are answering it.
Okay, sorry, yes, correct, sorry, beg your pardon. Thank you.
Hello?
Yes?
Hello? Hello?
Hello, Matt.
Can you hear me? I'm back.
Yes, we can hear you.
I'm back. I don't know what happened there, but the poll seems to be running.
Yes.
Good.
Have you got the final numbers of the poll?
I have.
Can I share them? Okay, great.
So I'm going to end the poll now. So we've got, so somebody obviously read the title of the talk. So 13% would offer support and reassurance scans, 65% progesterone, 14% offered aspirin and low molecular weight heparin, and 5% bed rest. So that's interesting. We're going to go back and share my screen now. Remember to do that bit. Now we should be back in the talk now. So what are her options, which we've discussed? So before kind of going through what different treatment options there are, when I did my research looking at sort of what women thought were the most important unanswered questions with miscarriage, we did a survey which went out nationally, and when we looked at the responses, by far the most common unanswered question that women had about miscarriage was why? What caused my miscarriage? Was causation. People were also bothered about kind of the support and emotional support for getting through their miscarriage or experiencing previous miscarriages, and then prevention. So they were the top 3 kind of unanswered questions with miscarriage. But this really is kind of the most important thing. And I think that this is really important to consider why the miscarriages happen before thinking about any treatments, what causes miscarriages. And yes, we know most of them are due to chromosomal problems because the embryo hasn't formed properly, and you get aneuploid embryos. But the honest answer for most women who have a miscarriage is like, we don't really know why it happened. And because we don't know why it happened, that therefore makes looking for treatments quite difficult. So when we completed the research looking at what the most important unanswered questions were in miscarriage, surprise, surprise, the one that was most important was research into preventative treatments. And we published this in 2017. And this really set the research agenda for miscarriage. You can also see the other things that were important with the emotional aspects, investigation, relevance of other medical conditions, importance of lifestyle factors, and male causal factors. But the most important thing, as you'd expect, would be what can we do to actually prevent miscarriage? So as part of this study, we did an extensive literature search, and we looked at the Cochrane database of systematic reviews, which is the highest level of evidence available. So I'm just going to flick out of the presentation for a second, and you should be able to see a document which summarizes all the authors' conclusions from Cochrane reviews for miscarriage treatment. And you'll see a pattern. We're gonna fly through them. But first of all, uterine muscle relaxant drugs for threatened miscarriage, there's insufficient evidence to support use. Bed rest during pregnancy, insufficient evidence. an interesting one, estrogen supplementation, so mainly diethylstilbestrol. No benefit, and obviously, as many of you will remember, this drug actually causes harm to the offspring and in terms of congenital abnormalities. So that's a really important thing to remember, that treatments that have been tried before have actually caused harm. Prevention of recurrent miscarriage for women with antiphospholipid antibody or anti-lupus anticoagulants. So this is one of the few systematic reviews, Cochrane reviews, that suggest that there may be some evidence, but essentially they still say that large randomized controlled trials are required, because most of the evidence for this comes from one study, and there's a lot of low quality evidence to support this. And this really at the moment, up until kind of recently, is the strongest evidence for any treatment to prevent miscarriage. HCG for threatened miscarriage, current evidence doesn't support it. Chinese herbal medicine, insufficient evidence, more high quality studies needed. Deflation of gastric band, further studies needed. Combined estrogen and progesterone, insufficient evidence. HCG for preventing miscarriage, it's equivocal. So, and on and on and on. Aspirin and heparin for women with unexplained recurrent miscarriage, with or without a thrombophilia. The review doesn't support anticoagulants at all. So really, there's only a bit of evidence for anticoagulants when there's antiphospholipid syndrome. Immunotherapy, no significant benefits. And then the topic of my PhD thesis, septal resection, there were no randomized control trials. So essentially, I'm not going to go all the way through. The only ones that have been updated recently look at progesterone, but we're not going to go into that into detail. Thyroid antibodies, no clear conclusions. So essentially, what does Cochrane say? It says that unfortunately there aren't really any proven treatments for miscarriage. So the options for our patient are quite limited. But then she asks, what about progesterone? I've heard something about it recently. There've been some studies. And that kind of got researchers thinking, and progesterone has been used for some time. And we all know of case studies like this. A young woman who's had 6 miscarriages before. I mean, she's in a really bad situation when she gets pregnant again. So bad that she goes to a doctor who, on really poor evidence, prescribes progesterone. And hey, what? She has a baby. She gets pregnant again. This time, progesterone is probably just fluke. So she doesn't have progesterone, and then she has a miscarriage. And then in a subsequent pregnancy, she definitely wants progesterone this time and has another baby. And we all know case studies like this, but you can't kind of base all your clinical practice on a case study of n equals 1. But this kind of gets us thinking about it. Maybe progesterone could be used as a treatment to prevent miscarriage. And why would it be useful? Well, the clue's kind of in the name. Progesterone, when you break it down, pro in favor of, gestae, pregnancy, and own is obviously hormone. So it's a pro-pregnancy hormone. When you look at it naturally, if you remove the corpus luteum, which produces progesterone, or you give anti-progesterone medicines such as misoprostol, which we use, can be used to terminate pregnancy, or to induce labor later on in pregnancy. So any stage of pregnancy, you use anti-progesterones, it ends the pregnancy. But that's all very interesting, but there's never been any human progesterone deficiency state ever described. Let's have a look at steroid hormones. And so progesterone, you should be able to see my cursor is just here. So it's right near the top. It's really closely related to cholesterol. There's only 2 enzymes that change cholesterol into progesterone. And there are conditions where there's genetic defects in these enzymes. But as far as I'm aware, they're not compatible with life. So we don't know of a state where there is no progesterone that can be produced. So why would supplementing progesterone make any difference? So really, this kind of gets us thinking, well, maybe it could be a treatment for miscarriage. So what do we need to do to test whether progesterone is going to be a decent treatment for miscarriage? Because we want some evidence rather than just it works for one patient. Well, first of all, we talked about this. There's no proven deficiency states, but potentially a cause for miscarriage that's been described is something called luteal phase defect. And many of you will have heard of the luteal phase defect, which we'll look at a little bit in a minute. Secondly, if the patient has this condition, you need to be able to identify an accurate test for the cause. Now, those tests could be salivary progesterone. It's easy enough to take a blood sample and get progesterone results back quite quickly. Or you can even look at the endometrial histology between cycles to see what effects progesterone's had on the endometrium. And then finally, once you've established a problem, you've seen that there's an association and a test to identify the problem, you need a treatment, which is progesterone. And we'll talk about progesterone in a minute, because the different preparations are not always the same. So let's have a think about this. So luteal phase defect could be a cause for miscarriage, but it's very poorly defined. The ASRM, the American Society for Reproductive Medicine, published a very good committee opinion paper on luteal phase defect. And essentially, while it's kind of theoretically could exist, it's not really defined. There's no tests to prove whether a woman has it or not. And there are no studies to actually show that women with a suspected luteal phase defect have any worse pregnancy outcomes than those who don't. It's not possible to do a test. The diagnostic value is unclear of salivary and serum progesterone levels. And when you have a progesterone level in early pregnancy, it's very difficult to kind of provide any prognosis from that result or direct causality. And so really, we need to find an effective treatment. And if we're using progesterone, who is it going to work for? So first of all, let's have a look at some of the evidence. So we'll start off with what the evidence was for using progesterone or progestogens to prevent miscarriage in women with recurrent miscarriage. Now, if you go back, I guess it's 9 years ago now since this meta-analysis was done, but these were the 4 studies that looked at progesterone supplementation to prevent miscarriage in women with recurrent miscarriage. And as you can see, 3 of the studies are way back, kind of over 50 years ago. And the 4th study in 2005 is still quite small. And so you can see that altogether less than 100 women were randomized to the studies. The first 3 all used diprogesterone, which is an oral preparation, which is not a synthetic, not a biosimilar or identical hormone to natural progesterone. I'm not quite sure what they used in the Elzibida trial. But when they put this all together, it looks kind of, the meta-analysis looks reasonably promising. You can see that it favors progesterone sort of quite convincingly. So Ari Kumasamy at this point thought, well, this is all very interesting. Perhaps it would make for a good trial. And that will be the PROMISE trial. So, but before we move on to the PROMISE trial, we just need to take a little detour to kind of think about, even if it does work, what would be a plausible effect size. And so really to kind of interpret PROMISE and PRISM, we need to have a bit more understanding about the trial design. So first of all, what might be a plausible effect size if you're going to give progesterone to women? Well, first of all, we said that miscarriages affect 1 in 4 pregnancies. So we've got a background rate of 1 in 4. So in your trial, still 75% of women will go on and have a baby if it's just, we're looking at the background rate. So only 25% of women in a trial may have a miscarriage. Half of them, let's presume, will be chromosomal in cause, and so progesterone is not going to improve anything. If it's if there's a genetic problem, progesterone is not going to work. Let's kind of take it that half of them are non-chromosomal, and that would include women that would have this luteal phase defect, which is poorly defined. So that leaves sort of 12.5%. And let's kind of presume that progesterone might help half of them, and that's quite a big effect size, that they might have a progesterone problem. and that progesterone might prevent half of those. So that's really only sort of 3.5% out of the total population. So really, the trials, the studies that we're looking at need to look for an uplift in live birth rate in the region of, I suppose, 3 to 4%, which is quite small. And the only way you can do this to detect an effect size that's small is to either a very large trial where you're looking kind of tens of thousands of women, which is very difficult to recruit to and to fund because trials are expensive, or you can use a process called enrichment. And what Ari decided to do was look how we can enrich the population. So enrichment, and these pictures kind of explain this. So on the left side, we have 1,000 women who are just 1,000 random early pregnant women who are unselected. And the problem luteal phase defect, let's say it affects 5% of the women. So let's presume it's the women with black hair in that picture. So it's quite hard to pick out how many have got black hair in that picture. And certainly if it was 1,000 women there that we're looking at, it'd be really hard to spot them, and there wouldn't be very many. So an enriched population is where you change the population to have more people that might have the problem. So you see on the other side, we've got 20% of women with black hair, so it's much easier to detect them. So how can we apply enrichment in our studies? Well, what we did is used previous miscarriage as a way to enrich the population. And now the reason why is quite clearly shown by this chart, which looked at the chromosomal analysis of pregnancy losses from women who have had previous miscarriages. And as you can see with the green or the bluey green bar at the bottom stays pretty constant. But as pregnancy losses increase, women are more likely to miscarry pregnancies with a normal carrier type, so have normal chromosomes. So this means that as we go further along this chart, we have more women with previous miscarriages in our study. It's more likely that they're having pregnancy losses that are not due to genetic abnormalities, so more likely to be for another cause, potentially a progesterone problem. So this really brings us on to looking at the two trials. So first of all, the PROMISE trial, which is progesterone to prevent miscarriage in women with recurrent miscarriage, and PRISM, which is progesterone in spontaneous miscarriage. So that's using progesterone as a rescue treatment. So the PROMISE trial, progesterone in recurrent miscarriage, was done in the UK and the Netherlands. It recruited women with unexplained recurrent miscarriages. So like our first woman in the case study, all the investigations were normal, and they were trying to conceive naturally. The intervention was 400 milligrams of progesterone. And it's interesting, this is where comparing studies, it's important to remember, is that it was vaginal progesterone, and that actually means it's that vaginal progesterone, I think, is made from yams. Mina will be able to tell us later, but it's a soya kind of bean product, and the progesterone is identical to progesterone which is produced naturally. In many places, you use oral progesterone in the past, which is a progestogen. And mainly, I think in the United States, there's a more propensity to use injectable progestogens. And they're also not bioidentical. So it's interesting that we're using sort of vaginal progesterone taken twice daily from basically a positive pregnancy test until 12 weeks gestation. Women either got that or they got placebo pessaries, and the outcome was live birth beyond 24 weeks. So the study had 826 women randomized. So if you think previously there were less than 100 women that have been randomized, this is at least 8 times bigger. And the primary outcome, which looked at live birth, showed a difference between the two groups of a little bit more on the progesterone side, 65.8, and the placebo group, 63.3%. So only about 2.5% in it. And unfortunately, to every kind of chief investigator's disappointment, the overall kind of confidence interval didn't show any difference. So kind of at face value, unfortunately, progesterone supplementation didn't reduce the risk of miscarriage or increase the live birth rate. But as you think with all trials, you need to look into things a little bit deeper. And this brings us back to the thought about previous pregnancy losses. But first of all, before we move on to that, let's just do another poll. So we've got a 32-year-old woman who's had 6 miscarriages before. She's not had any babies. Investigations are normal, and she's asked for progesterone. So based on the PROMISE trial results, would you recommend progesterone for this woman? So we're going to get the next poll up. Let's just unshare my screen. Polls. Oh, my polls disappeared. We'll go yes. Right, so would you prescribe progesterone for this woman? Right, so we'll end the poll there, and we can see that 86% of you would prescribe progesterone and 13% wouldn't. So that's interesting. Maybe you guys aren't listening. I just showed you that the PROMISE trial showed that progesterone wouldn't work. But I guess perhaps some of you saw the next slide, which looks at the effect of previous miscarriages. You've got to remember, as they go along, and we went through this before, with the more miscarriages you have, more likely they are to lose a normal pregnancy rather than a chromosomally abnormal pregnancy. And if you look at the subgroup effects, you can see that with 3 pregnancy losses, progesterone didn't seem to make that much difference, only about a 0.5% increase, which is not statistically significant. But interesting, with 4 previous losses, there seems to be a bigger difference. 5, a bit more bigger difference. And with 6 or more miscarriages, so our patient we've just talked about, there's maybe a 7% uplift from 57% versus 50%. But because the numbers are quite small, none of these become statistically significant. So at this point, we're kind of left a little bit disappointed in that we can see something that potentially is making a bit of a difference, but this it's not statistically significant. But there's this thing that we can see called a biological gradient. So the pre-specified analysis, which is what the authors said they were going to do before they unblinded the trial, showed that with more than 4 miscarriages, it's slightly more effective, but still not significant. But the really interesting is when you look at 3, 4, 5 or greater than 6, is that it's not just randomly dotted about these. There seems to be a kind of gradient towards favouring progesterone based on the number of previous miscarriages. Now at this point, so this study was published in 2015, I think 2015, 2016. I don't think we really have the evidence to kind of definitely say that progesterone is going to work because it's not significant, but it makes it really interesting when we look and analyze the next study, the PRISM trial, looking at progesterone in spontaneous miscarriage. And the reason why is this biological gradient, which we're going to come back to shortly. So PRISM is using progesterone to basically is a rescue progesterone. So when you have early pregnancy bleeding, a threatened miscarriage, you start progesterone supplementation, and does that reduce the risk of miscarriage? So the meta-analysis before this study was done, the study is a little bit newer than with recurrent miscarriage, but still not very many patients. Like the biggest trial is Pandion 2009, looking less than 200 patients, 191 patients in that trial. But again, you do the meta-analysis and it starts to look, you've got the diamond favouring progesterone again, and it kind of makes for a good trial, really. And that's why NIHR, the National Institute for Health Research in the UK, funded the PRISM trial to several £million. And PRISM, so it looked at women with early pregnancy bleeding, exactly the same treatment as the PROMISE trial, 400 milligrams vaginal progesterone until 16 weeks from bleeding. Comparison was placebo, outcome live birth beyond 34 weeks. Now, the PRISM trial was much bigger than PROMISE. So there were 4,153 women recruited to the trial, and only 3% were lost to follow-up. So you've got primary outcome data for about 4,038 women. And you've got to think this is 20 times bigger than the Pandion study in 2009. And what you can see looking at the primary outcome is that with progesterone, you've got a 3% increased birth rate than with placebo. And this is looking at everyone altogether. That means that there's 54 extra babies in the progesterone group than the placebo group. And when you look at the confidence interval, the p-value lands at 0.08, so very near the magic 0.05. And when you look at this on the chart, you can see the bottom whisker just touches 1. So it's very much kind of looking as though progesterone may be favourable. But there's always this slight doubt, perhaps it's not. But then let's look at the subgroup analysis. But before we get to that, I keep missing out my case studies. We've got a 27-year-old woman. She's had 1 previous miscarriage. She's 6 weeks pregnant. She's really anxious because of getting COVID, and she has got some spotting, and so she's rung you up and is asking for you to prescribe her progesterone. So based on the PRISM trial, with a previous miscarriage, 6 weeks pregnant, I've told you it's not significant, who would prescribe her progesterone? So this is going to be our last poll. Let me set the poll. There we go. Off you go. Whilst we're doing that, I'm just going to have a scroll through the chat. So it's interesting, yeah, a few people saying that in their own practice, they think that natural progesterone does help in early pregnancy. And is really interesting. You've got to remember that those levels of evidence as well. And yes, there's always at the bottom of the pyramid, there's everyone's kind of personal or expert opinion. But we still have to kind of think, look, we really need good quality evidence to recommend these things. So let's go back to the poll. So it's a bit closer on this one. 71% of you would prescribe progesterone for this patient, and 28% of you wouldn't. So let's look at the subgroup analysis. So on this one, number of previous miscarriages, 1 to 2 miscarriages, you've got a slightly bigger difference. So with no miscarriages, there's only that the live birth rate is slightly higher in the placebo group, but with as the number of previous miscarriage increases, a bit like the PROMISE trial, you get a bigger effect size, and the p-value becomes significant as we move further down. And with any number of previous miscarriages, you've got a 5% difference in the live birth rate. So 5% might not sound like a lot, but I'm sure if you ask a woman with early pregnancy bleeding if they want to improve their chances of having a baby by 5%, many of them would snap your hand off. Now, this kind of shows the biological gradient again, as you can see, with the number of previous miscarriages. It's even a bit more obvious than with the PROMISE trial. You've got this gradient over, which is showing a larger effect size. And you've got to remember, because the PRISM trial is much larger, you've got much bigger numbers, so the confidence intervals are much better than with the PRISM trial. So if we put both of them together, the overall effect on live birth, you can see that that again, we're kind of favouring progesterone. So it looks like perhaps there is something there after all, despite on the headline figure saying that both of the trials didn't make any difference. So let's have a think about the implications for practice. So who should we prescribe progesterone for? Should we prescribe it to women with recurrent miscarriage, women with higher order recurrent miscarriage, women with threatened miscarriage, or women with threatened miscarriage and a miscarriage history? So these are kind of 4 groups that we could put them into. I suppose group 1 and group 3 are what PROMISE and PRISM's primary outcome looked at, and group 2 and 4 are what the subgroup analyses looked at. But I think before prescribing anything, we've got to really think back to kind of like principles of prescribing and what our values are as doctors. And you've got to remember that the first thing we agreed to do as doctors is first do no harm. And when you look at the stories in the past of things like diethylstilbestrol in early pregnancy and congenital anomalies, things like thalidomide, we really want to kind of make sure we're not doing any harm at all. And that's why it's really important that these data were collected from both of these large high quality trials, which essentially showed that the rate of congenital anomalies are no different between the 2 groups. And that kind of makes sense as well, because the progesterone that was used is completely the same as natural progesterone that's produced by kind of our bodies rather than something synthetic. So that's quite reassuring, although obviously we still need to follow up on data going forward. So going back to our first patient who has had lots of miscarriages and presents with some spotting and says, "Doctor, please help." So what are your options now? Well, really, when going through the Cochrane review, and as long as she doesn't have antiphospholipid syndrome, I think that really the only option available to her is progesterone. And while we wait for the evidence to be synthesized and guidelines such as NICE to be updated, Tommy's and Birmingham and Harry Kumasamy, who ran the trial, and this is what we recommend in the AJOG paper as a suggested protocol. So for women who are less than 12 weeks gestation, so if they're in early pregnancy, if they don't have any vaginal bleeding and they've got less than 4 previous losses, then there's not so much evidence to kind of recommend progesterone treatment. But certainly for 4, if they've got 4 or more losses, then progesterone could be used, and the number needed to treat is 14 pregnancies to prevent a miscarriage. Going back to the top, less than 12 weeks, and this time they've had threatened miscarriage, they present with some bleeding. Then if they've had a previous miscarriage, so any more than 1 previous pregnancy loss, and you give progesterone, if they've had 1 or 2 previous miscarriages, the number needed to treat is 25. And if they've had 3 or more miscarriages and they have early pregnancy bleeding, the number needed to treat is 8. Now, I think it's worth kind of thinking about these numbers needed to treat. And sometimes 25 sounds like quite a lot of people to give a medicine to prevent something. But if you compare this to something like aspirin to prevent a heart attack, you're looking at studies for a lot of cardiovascular medicines of numbers needed to treat in the hundreds to prevent 1 heart attack or death. Whereas the numbers needed to treat are really quite small. And if you think about it, it's not just number needed to treat to prevent a miscarriage, because if you prevent a miscarriage, it's a binary outcome. You're actually giving someone a baby. So it's really quite a small number needed to treat to prevent miscarriage and to help women have more children. So what I want to kind of finish this with is we did have a video here. Here we go. Let's see if we can play the video. Don't know whether you're going to get the sound. Don't know if you can hear the sound, but if not, it's just some music. There we go. So I think that kind of video is really interesting. And normally when you see fancy graphics like that, it's produced by the pharmaceutical companies trying to sell the product. But this was actually something that's been produced by Tommy's the Baby charity in the UK, who help support this kind of research and are there to improve care for women. So I want to say thank you to these two influential people on my career and also on the research that's been done. So first of all, Professor Ari Kumasamy from the University of Birmingham, who ran both PROMISE and PRISM trials and provided us with the evidence and the kind of topic for discussion tonight. And then Professor Jim Thornton, who you may or may not have heard of. He's an obstetrician and consultant in Nottingham. He's been around for some time. He's an arch skeptic. He doesn't believe in anything. And he's taught me to be very critical of the data. I think that's why I, looking through the data, feel that progesterone perhaps does have a role in the future of preventing miscarriage. So I'll leave you with the, I don't think I can leave the suggested protocol up because I'm going to have to come out of my presentation so I can see the screen, but you'll be able to get access to these slides and I think the presentation for a few days afterwards. So thank you very much. I hope that was helpful.
Thank you, Matt.
Thank you.
Thank you very much, Matt. For a very clear and concise presentation. We've had many questions, but what we'll do actually is we'll go to Mina, who will just do a very short presentation for 5 minutes on Cyclogest, and then we will compile all the questions at the end because we have many coming through for you. So we will let Mina do his presentation, and then we will finish the webinar with the question and answer session. Thank you.
Okay, good evening. In this very short presentation, I will be presenting to you Cyclogest, which is an effective luteal support helping to deliver little miracles. When we see different progesterone preparations or progestogen preparations in the market, they are very different in terms of the origin of the progestogen molecule, the route of administration, and the dosage form. So the question is, which progestogen preparation is better for patients suffering from luteal phase defect, history of preterm labor and birth, or recurrent miscarriage? What we recommend is to use the natural progesterone in the vaginal dosage form, vaginal pessaries, and with a flexible route of administration between vaginal and rectal, which is cyclogest. Cyclogest, what we will discuss about it is 3 brief points. First is cyclogest as the natural choice. Second is cyclogest and its unique pessary formulation and the unique mode of administration. Finally, cyclogest and the uterine first pass effect. Cyclogest is the natural choice because cyclogest progesterone is natural, biosimilar, and bioidentical to what the body produces. As you can see here, the natural progesterone is exactly the same as the progesterone used in cyclogest. So it's bioidentical and biosimilar to the natural progesterone. The bioidentical progesterone molecule in cyclogest mirrors the binding affinity profile of the bodily produced progesterone on different receptors. So when we look here, we see that the natural progesterone has a role in immune modulation and maintenance of successful pregnancy. We see here the relative binding affinities of progesterone and synthetic progestins to the steroid receptors and the serum binding proteins. And as we can see here, that only progesterone, the natural progesterone, has a binding affinity towards the glucocorticoid receptors, mineralocorticoid receptors, and corticosteroid binding globulins, compared to no affinity with the synthetic progestins. This means that natural progesterone has a role in immunomodulation and maintenance of a successful pregnancy. Moreover, the progesterone in cyclogest, being natural progesterone, it has a more favorable safety profile compared to synthetic progestins because natural progesterone has no risk of interference with the unborn fetus, unlike many reports with synthetic progestins. Also, progesterone was associated with lower risk of breast cancer compared to synthetic progestins when each is given in combination with estrogen, and the relative risk is almost 33% less. Moreover, vaginal progesterone has a more favorable tolerability profile and a more favorable safety profile, not only being natural progesterone that is used in cyclogest, also the vaginal administration. Vaginal progesterone has a more favorable tolerability profile compared to injectable progestins, and cyclogest was the preferred route of administration for patients versus intramuscular injections of progesterone oil, and it was superior in terms of convenience of administration, ease of administration, and the overall satisfaction of administering or dosing. Also, vaginal progesterone has a more favorable safety profile compared to oral progestins because cyclogest, by avoiding the hepatic first pass metabolism, the vaginally administered cyclogest avoids the formation of psychoactive metabolites by the liver, and cyclogest had a significantly lower risk of bleeding, nausea, and epigastric pain compared to oral synthetic progestins. And this takes us to the second point, which is the uterine first pass effect of cyclogest. Having mentioned that it's a vaginal progesterone and the superiority of vaginal progesterone over intramuscular and oral in terms of patient's convenience and in terms of tolerability profile, cyclogest has a more favorable first uterine first pass effect. The vaginally administered micronized progesterone ensures local targeting of progesterone with increased local endometrial concentrations and lower serum concentrations versus intramuscular progesterone. And we see here that the endometrial concentration is almost 30 times higher with women who administered vaginal progesterone compared to women with high serum progesterone after intramuscular progesterone. So cyclogest provides a targeted drug delivery to the uterus. Also, the first pass uterine effect of cyclogest, it has a more favorable effect than oral dedrogesterone on the uteroplacental circulation in early pregnancy complicated with threatened abortion. As we see here, that the vaginal progesterone administration, but not the oral dedrogesterone treatment, resulted in the decrease in the spiral artery pulsatility and resistance index and systolic diastolic ratio. Finally, achieving higher local endometrial concentration in a comparison of the endometrial histology between vaginal micronized progesterone versus oral dydrogesterone. This is a representative endometrial biopsy on day 21 of an artificial cycle after micronized progesterone. Patients with premature ovarian failure received estrogen from days 1 to 21 and vaginal progesterone from days 15 to 21. And then we found out that the maturation corresponded to day 6 of the luteal phase with cyclogest treatment compared to maturation corresponding to day 2 to 3 of the luteal phase with the oral dydrogesterone treatment. So vaginal administration of micronized progesterone in women with premature ovarian failure results in a significantly more in-phase endometria when compared to oral dydrogesterone. And not only compared to oral dydrogesterones, but also in comparison to progesterone vaginal gels, cyclogest 400 milligrams twice daily gives an adequate endometrial response rate in 94% of the treated women. And we can see here that cyclogest replicates the natural luteal phase, providing support until the embryo becomes dependent on the placenta. And here, the 400 milligrams twice daily of cyclogest provided adequate response in 94% of the women and late secretory state in 90% of the women, compared to 90% and 82% with vaginal progesterone gels. And this takes us to the unique pessary formulation of cyclogest. Like, how is it different from the other vaginal micronized progesterone preparations? Cyclogest's unique pessary formulation, it's formulated with the unique Sapphire BS2 wax progesterone pessary, which has a melting range between 36 and 38 degrees. This unique Sapphire BS2 wax provides two important advantages. First, it provides a gradual melting with relative hydrophilic properties. So it gives cyclogest a slow release of progesterone, allowing twice daily insertion with a steady serum concentration after 4 and 12 hours. So twice daily covers the 24 hours. In addition, it is self-lubricating, which aids in painless insertion, and application is neither painful nor messy. Not only the easiness of the application, but also using the BS2 Sapphire wax, cyclogest has a unique mode of administration. Cyclogest is the only progesterone with a convenient, flexible use. Cyclogest can be used for comfortable vaginal administration, easy self-insertion by the patient. No applicator is required for perivaginal insertion, and also with the option of rectal insertion, which is preferred in certain medical conditions. And also it provides sustained and similar plasma concentrations compared to the vaginal administration. And the perirectum is preferred actually in many cases, like virgins suffering from premenstrual syndrome, vaginal infections, discharge from the vagina, patients who often have cystitis, recently given birth, placenta previa patients. So this takes us back to the first question that we asked, which is which progestogen preparation to choose for those patients. Actually, if we choose cyclogest, we choose a natural bioidentical progesterone, which provides optimum efficacy and safety, which is bioidentical and biosimilar to the natural effect of progesterone, and with a similar safety profile to the naturally available in the body progesterone. Second is, if we choose cyclogest, we choose a targeted drug delivery system that avoids the hepatic first pass metabolism, so we avoid the side effects of oral progestins, and also it achieves a uterine first pass effect by gaining the optimum endometrial progesterone concentration. Third, if we choose cyclogest, we choose convenience and flexibility by providing the unique vaginal and rectal insertion with twice daily, and also it provides convenience by the self-lubricated cyclogest pessaries. And this takes me to the conclusion about choosing cyclogest. in a survey that have shown that Cyclogest is Britain's first choice, and Britain, as you know, is the home country of Cyclogest. In a survey that was done in 2013 of luteal phase support preparations, which were done in UK IVF clinics, and they surveyed almost 58,000 cycles of IVF, and they found that Cyclogest pessaries were the preferred choice in 85.1% of the responding clinics, compared to 10.8 clinics for the vaginal progesterone gel, 2.7% for the intramuscular preparation, and 1.4% for utrogestin per vaginal pessaries. Thank you very much for your attention. So this was a brief introduction to Cyclogest, and now I leave the floor again to Gerard and Dr. Matt for the question. Thank you.
Thank you, Mina, and thank you, Matt. We've been having very substantial amounts of questions on this topic. It's been a very important topic and widely discussed on the private chat forum and also the public chat forum. Dr. Matthew, a few questions to you to start. To which extent is progesterone beneficial to secure pregnancy for cases with a history of early miscarriages?
I think that kind of sort of summarizes the whole talk, really. Can you hear me?
Yes.
All right, good. Basically, if someone's had a previous miscarriage, or they've had, and they have early pregnancy bleeding, or they've got a history of 4 or more miscarriages, I think there's really good evidence to support the use of progesterone from the PROMISE and PRISM trial. I think that basically summarizes everything for that question.
Okay, next question is, what is the duration of treatment with progesterone for cases suffering from threatened abortion in early pregnancy?
So it's an interesting one, because I mean, theoretically, you would supplement progesterone until the placenta sort of takes over and produces enough progesterone naturally. So you could maybe think that would happen by 12 weeks. But in the PRISM trial, they gave the progesterone up until 16 weeks. And that might be a time when you think about starting it to prevent preterm birth, for example. So I think based on the evidence, I'd recommend up till 16 weeks. And that's what we will practice in our practice.
Okay, thank you. Next question is, what about progesterone combination treatments for cases of recurrent miscarriages?
So recurrent miscarriages, I think if there's several miscarriages that have been investigated and you can't find a cause for it, so I mean, if you find that the woman has antiphospholipid syndrome or another cause for miscarriage, or they keep having chromosomal miscarriages because they might have an unbalanced translocation, then it's not likely to work. But most, like we were saying at the start, most miscarriages, you can never really know why they happened. And you can say to patients, look, we have this treatment, it may work, it may not, but in studies it shows that you have a 5% increased chance of having a baby if you take it. We think it's safe. You have a reasonable conversation with the patients, and if most patients are begging you to prescribe it.
Right. Okay. Thank you. Next question is there a clinical benefit of the high endometrial concentration associated with vaginal progesterone over oral progestins?
I think that we don't know whether it's to do with because of the higher endometrial concentration, but if you think about it, you take tablets, they've got to go through your whole body, they've got to go through the liver and be metabolized. Also, the oral progesterogens are not progesterone, so they're not a natural progesterone thing. So by taking vaginal progesterone, it's biosimilar, bioidentical, and it's getting to exactly where you want it.
Okay, thank you. So many more questions. When should we start with vaginal progesterone for cases who have history of preterm labour, and to which week of pregnancy?
So I think that progesterone's often, because of going back to the slide that says it's all in the name, it's a pro-pregnancy hormone. It's been used for kind of anything to do with pregnancy, including preterm birth. And again, with preterm birth, there's many different causes for it. I'm not an obstetrician anymore, and the evidence for preterm birth is slightly different. So it's probably the topic for another presentation. So I think really you need to consider that if someone's having repeated pregnancy losses and it's throughout different gestations, because it tends to be a different issue. Either people have recurrent miscarriage or they have had several preterm births before. It's very rare for them to have both.
Okay. Would you advise patients to supplement with other ovary health supplements as well as progesterone?
I don't know what you mean by other ovary health supplements. Can't get my words out. Because as far as I'm aware, there aren't really any with good evidence. If you're thinking about things like inositol or DHEA, which often we use or is considered in kind of reproductive medicine and IVF, the evidence for those is like shockingly poor, especially compared to what we've just been through this evening. So it's really only progesterone for miscarriage that I would recommend treatment for.
Okay. A question related to that is Cyclogest always seems to be prescribed with IVF and ICSI patients regardless history of miscarriage. What's your opinion on that?
Yeah, so I mean, I spend most of my life kind of doing IVF and ICSI, and you've got to think about the reason why we prescribe it in these circumstances are a bit different. So women haven't gone through a natural conception. So if they have had a fresh cycle, they've been pumped full of drugs to stimulate the ovaries, and they won't necessarily have a corpus luteum that's producing progesterone naturally. So it's really important that we replace that with luteal phase support. So that's why it's always given in those circumstances, even more so with a frozen cycle, a medicated frozen cycle where frozen embryo is transferred. A woman will be producing no progesterone naturally herself. So it's absolutely essential to have luteal phase support. So we don't just give progesterone to women who are having IVF or ICSI because we're trying to reduce miscarriage. We're giving it to actually replace what they should have had naturally.
Okay, thank you very much. Another question is, to which extent do you have vaginal progesterone treatments can substitute cervical cerclage with cases who have been investigated with short cervix less than 25 mm from week 18 to week 24 of pregnancy?
So that again is really looking at progesterone for a completely different indication, which is to prevent preterm birth. Now, I have done sort of research in that area as well, but like I said, I don't practice obstetrics at the moment. Okay. I know the NICE guidelines recommend it in those circumstances, but the data is a bit kind of hit and miss in those areas, and I don't think it's as strong as for early pregnancy, even though that's been what I suppose obstetricians and gynecologists have been used to using progesterone for in the last sort of 5-10 years.
Okay. More questions coming in. What is the duration of treatment with vaginal progesterone for cases who have early pregnancy complicated by threatened abortions?
So I think, again, that goes back to just the way I kind of see things is that if you've done a randomized controlled trial and you've got evidence to show that it works, probably the best thing to do is to follow what they gave in the trial, which was 400 milligrams twice a day from when there was bleeding until 16 weeks gestation. So that's how long I'd use it for. The PROMISE trial was a bit different in that it was from a positive pregnancy test to 12 weeks gestation. So I would think somewhere between sort of 12 to 16 weeks, depending on the indication. It's supposed to be on the safe side. You think you're talking 16 weeks.
Okay, thank you. More questions. Somebody's asking, there's a recurrent preterm at 23 weeks with failed cerclage for 4 times using Cyclogest, but they failed. What is your advice?
Probably not a progesterone problem. It could well be short cervix, infection, cervical incompetence sounds more like the diagnosis rather than a progesterone defect. It's a really tricky one, that.
Okay. A popular question asked a number of times: is there any side effects or with taking progesterone at any time?
Yeah. So I mean, but kind of is based slightly on the route. So injections are really painful, so people don't really like the injections. If you take it as a tablet, oral progesterone, you can get progesterone side effects such as like premenstrual syndrome, get GI upset. With vaginal progesterone, you don't get those same systemic side effects because it's a more local effect. The downside of vaginal progesterone supplementations are that it comes in a wax, so they tend to they can cause sort of discharge and apparently completely destroy women's underwear, and they need lots more underwear whilst using it. They're the main side effects with it, really, but less systemic side effects with vaginal or I suppose rectal progesterone.
Okay, thank you. Another question come in and said somebody that worked with Jim Thornton as well said
Yeah.
he used to. What's your thoughts on hydroxyprogesterone? They said it's used in the UK, but they've not seen it used in this region much. What's your opinion on that?
So I've not really used hydroxyprogesterone before, and I think that depends on the indication, and like in these circumstances, when we're talking purely about kind of pregnancy loss, I think the only thing that's got good evidence is micronized progesterone, which is identical to natural progesterone. I mean, if you're using progesterone for progesterone component of HRT, or you're using it for bleeding problems or something else, then I guess it's less important. It's more about whether women can sort of manage the side effects, which route they'd rather take it. But taking progesterone to prevent pregnancy loss, I think there's only really good evidence for vaginal progesterone.
Okay. People asking, do you use different types of progesterone at the same time for any reason?
No, I've just used one type.
Okay, and I think we have some more questions. Bear with me. Is there a role for progesterone therapy with post-term pregnancy or an increased rate of CS?
I don't think there's any evidence that taking progesterone will mean that women are more likely to go over their due date. I don't know. I honestly don't know the answer to that one. I can't see why it would.
Okay, thank you. I think that rounds up the scientific questions. If I can invite Mina back in to see if he would like to have any questions to Matt. You're on mute, Mina.
Yeah, okay. I just want to thank you very much, Dr. Pryor, for the informative presentation. I can see in the comments, actually, everyone is appreciating the content that you have provided. So we thank you very much. And also, thank you so much for all the attendees. We had almost more than 500 attendees who attended this session live. So thank you all for making the time to attend this presentation and for your interaction and the questions. And I wish you a lovely evening. Thank you.
Thank you, Mina. Thank you, Matt. I'll just do a final roundup before we end the webinar. Yes, as you're right, we had over 500 attendees. You will have a replay link sent to your email a few hours after this webinar is completed. The webinar will be active for 3 days after the event. You will receive your certificate of attendance via email 3 weeks after the event. We would like to thank Lunatis for the sponsors of this conference, and to Dr. Matthew Pryor from Newcastle, UK, to give a very, very informative and interactive webinar, one that I clearly see the attendees thoroughly enjoyed. So thank you to you both. Unless there's any final thoughts from either of you, I will finish the webinar now.
Thank you.
Thank you. Take care. Bye-bye.
Thank you very much. Thank you, Dr. Pryor. Thank you.